It's Sarah here from BJC Health, coming to you from Sydney, Australia. Thanks for showing an interest in one of our educational events. You're about to watch part one, so enjoy the event. If you've got any questions about the content, then please consider joining BJC Connect, where you can access all of our facilitators live. Otherwise, please consider leaving a comment and we'll do our best to get back to you.
Good evening. Thanks for joining. Okay, look, I think the topic was hand arthritis and tendonitis, but I thought I would expand the topic a little to talk about hand and wrist pain as such. I think we'll cover a few more things. Now, as a rheumatologist, it is not uncommon to get referral to see patients with painful hands. I reckon it's one of the most complex part of the body and can be affected by many, many different conditions. When I see patients with hand and wrist pain, the first thing I do is to determine whether it is an arthritic process or whether it is more a tendonitis problem or some other unusual features in the history to suggest a nerve issue or unusual pain syndrome. So that's my thought process. Now, I'll briefly talk about these conditions later on, and I'll ask Michele to chime in to talk about the management of a few of these conditions. Now, if I move on to slide that, I think it's very useful to go through some basic anatomy. So I hope all of you at the end of this evening will learn a few medical terms, and when you go back to see your doctors, you'll impress them by using medical terms. Okay, now, so let's start with the bones and the joint. So that's the picture of our hand. So we have the forearm bone, then we've got the carpal bones, then we've got the palm, which makes up of metacarpal bones, then we've got the fingers. The wrist joint itself is an articulation between the forearm bones and the carpal bones. Now, you can see that there are quite a few bones in the carpal bones. And they've got very difficult names to remember. When I was a medical student, I hated remembering them. And I reckon after remembering them, passing the exam, I forgot half of them. Now, medical students had to be creative and use mnemonic to remember them. And I remember at that time, I used this one. This was the most popular one. We got scaphoid, lunate, triquetrum, pisiform, trapezium, trapezoid, capitate, hamate. So it made up of this. I remember she likes to play, try to catch her. So I was curious. It's been like 20 or 30 years since I did my med school. I wanted to know the latest. So I went to Google. At that time, there was no internet. So last night I went to Google and tried to see what's the most commonly used mnemonic nowadays by medical students. They're not very creative. Some lovers try positions that they can't handle. I Googled that became the most popular mnemonic. So anyway, so we've got the carpal bones, that's the wrist joint, the palm, they're the long bones, they're the metacarpal bones. The fingers, the medical term for fingers are phalanges. And there are 3 bones for each finger. We name them proximal because that's the closest, proximal phalanx or phalange, the same, middle phalange and the distal phalange. So each finger has 3 bones except the thumb. Now, all together, our wrists and fingers, we have 27 bones. So that's a party trick you can tell your friends. I know all the names of the carpal bones and I know the latest mnemonic. Let's move on. Now, the joints in our hands are not too difficult to remember. Remember, we've got the metacarpal bones, then we've got the phalange. So these joints are the knuckles of our hands, the first row of knuckles. We call that metacarpal phalangeal joint. Short term for that, MCP joint. So MCP joint. So when you see a doctors, I've got MCP joint pain, then they'll know what you're talking about. Then the fingers, the middle row of knuckles, because it's between the phalanges, we call that proximal interphalangeal joint, PIP joint, right? So you go, PIP joint, my PIP joints are sore. Your doctors will know which joints you're talking about. Then The distal row is distal interphalangeal joint, DIP joint, right? Okay, so you can remember MCP, PIP, DIP. Then you really impress your doctors. Now, apart from the bones, we've got even more complex structures, the tendons on our fingers. Now, these tendons are responsible for us for bending our fingers and straightening our fingers. And there are these structures here called pulleys. You can think of them as anchors to tie the tendons down onto the bones. They can be a source of a problem later on in our lives. Then we've got numerous little muscles in our hands called intrinsic muscles, and they are very difficult to remember. I think only hand therapists like Michele knows the name. So that's how we get our dexterity of our fingers. Okay, let's talk about hand arthritis. So as a rheumo, when I see a patient with whom I suspect with hand arthritis, I want to know the pattern, because the pattern can tell us a lot of things. A quick summary: osteoarthritis, that's age-related degeneration, usually affects the DIP joints, that's the tip, the middle row, PIP joint, maybe the two knuckles, MCP here, but very common to affect the base of the thumb, called CMC joint, the base of the thumb. And I'll talk about that in a minute. There's a different type of osteoarthritis with a lot more inflammatory activity, with some erosion. We call it erosive osteoarthritis. But the one people talk about most is actually rheumatoid arthritis. And for those who have attended our previous lectures, you probably heard other speakers talk about rheumatoid arthritis being an autoimmune disease causing inflammation in the joints, and you don't get it treated right, you get deformity and twisted fingers. Rheumatoid arthritis affects the PIP and MCP, and often not the DIP. So if you've got the tip of the fingers, the DIP joints involved, then it probably is not rheumatoid arthritis. You have to think about osteoarthritis or psoriatic arthritis, right? But not typical rheumatoid arthritis. So I briefly talk about rheumatoid arthritis. It's an autoimmune disease. If you don't treat it right, you get twisted fingers. Now, there are many other different forms of arthritis, and they look different on X-ray. So I won't go through this slide. And this is what rheumatologists do when we look at X-rays. Now, the symptoms, when we suspect someone has hand arthritis, we want to determine whether the person has inflammatory symptoms. What that means is being worse in the morning. So a person can wake up feeling horribly stiff and sore in the fingers in the morning. Worse in the morning. Stiffness and pain and difficulty bending the fingers at least 30 minutes, if not hours. And as the day goes on, they get better. Whereas osteoarthritis in the morning, yes, you get a bit of stiffness, a bit of soreness, but not too bad. But the more you use the joints, the worse they get. So it tends to be worse with activities in the afternoon. So that's the classical presentation. But in real life, things are never that straightforward. We get a mixture of symptoms because people can get osteoarthritis and later on develop rheumatoid arthritis. So we have to be very careful in interpreting the symptoms. Now, all right, we look for other clues. Sometimes the history is not so helpful. The other clues we check is whether there's a family history or personal history of psoriasis, because 30% of patients with psoriasis, which is a skin rash with flaky skin, can get inflammatory arthritis. If a person has multiple episodes of unprovoked tendonitis or tendonitis not related to overuse of physical activities, then we think whether there is an autoimmune process going on. Enthesitis is a term to describe attachment point inflammation. For example, the muscle of the forearm, when that sticks onto the elbow, we call that tennis elbow, yeah? Or behind the heel, the Achilles attachment, we call that Achilles enthesitis. If a person has unprovoked inflammation in these areas, we think about psoriatic arthritis. Then we look at fingernails, for example, thickened nails or with pitting and ridges, then we suspect psoriasis and psoriatic arthritis rather than simple osteoarthritis. Okay, in terms of investigations, we'll start with simple x-rays, but in early diseases, x-rays are not helpful. We do some blood tests for rheumatoid arthritis antibodies and other markers, in particular ESR and CRP. Now, these two markers are inflammatory markers. They go up when there is inflammation in our bodies, but it doesn't tell us where the inflammation comes from. If a person has a cold or flu, that will go up. But in the absence of an infection and a person has an inflammatory arthritis, yeah, they can be high. That can be a clue. Uric acid, yes, gout can affect the hands, usually in the later stage of the disease activity. And we do ultrasound to look for active inflammation. And in some patients, we even do MRI scan of the hand to look for inflammation. So that's a quick rundown of hand arthritis. And I thought I'll spend a bit of time to talk about this joint here. The first, carpal metacarpal joint, CMC, carpal metacarpal joint, because it's a very common joint to get osteoarthritis and pain, very common. And I'll ask Michele to talk about management in a second. So the pain is right there at the base of the thumb. And the joint is between a bone called trapezium, that I remember, trapezium, and the metacarpal bone, right? So left side of the screen, quite healthy bone, quite healthy joint with a gap. Right side of the screen, you can't see the gap, and the joint looks not so happy. So that's typical osteoarthritis of the first CMC joint. Broad principle, we try to get Michele or other hand therapists to make a splint, and exercises can help this a lot. Of course, there'll be behavior modification that the hand therapists will help our patients with. Analgesia-wise, starting with Panadol, paracetamol, or Voltaren creams, sometimes can work. Sometimes we organize cortisone injection to settle the pain and the inflammation. And lastly, nothing worked, then we send the person to a hand surgeon to remove that little bone, the trapezium bone. The procedure is called trapeziectomy. So I might pause here and ask Michele to take over to talk about management. Let me jump out of share screen.
Thanks, Herman. Did anyone have any questions before I get started, or everyone's pretty happy with what Herman's said and there's no burning questions at the moment? All right. I'm assuming that's a no, since Robin's not shaking her head at me. So as Herman was kind of saying, arthritis at the base of the thumb is probably one of the most common areas that people get pain. And the reason for that is, as you can imagine, in terms of using your hand, your thumb is pretty much involved in every activity. So the base there is pretty much the most common place where people first start experiencing pain. There's lots of things that we can kind of start doing, but one of the things that we do like to do, as Herman mentioned, was often making people a splint. And the idea behind it is, as you can imagine with any kind of arthritis or inflammation, is a lot of the times somebody has done something and they've just overused their joint. It creates a little bit of inflammation, a little bit of swelling, and a little bit of pain. And then what happens is you keep using your thumb or wherever, and it creates a little bit more inflammation, a little bit more swelling, and consequently a little bit more pain. And what happens is people keep going around this cycle. Okay, so it slowly gets worse and worse and worse and worse and worse until it's so sore they can't use their thumb. And that's usually when they like to come to see us. Okay. So as you can imagine, in terms of conservative management or things that, doctors can't do, so not invasive things, what we want to do is we just want to break the cycle. So the idea behind the splint is we force your thumb to rest, okay? A lot of the time, people can't think, I can just stop using my hand. It's actually quite hard because, as you can imagine, whether you're right or left-handed, you don't realize you actually use both hands for quite a lot of things. So often we just give people a splint. Super simple. We show people what to do in terms of either heat or ice and maybe some simple massage. And that might be just for 2 weeks, okay? If you wear your splint for 2 weeks, close to full time, what I find is a lot of people will significantly improve, okay? And that's basically my point where I want to see. If you have significantly improved after wearing that splint for 2 weeks, then I'm actually really, really happy, okay? And that's the point where I kind of say, hey, I can start getting you out of your splint slowly, and then we can actually work on strengthening and stabilizing your thumb, okay? Because long term, we don't want you in your splint full time, because that means your muscles get weak, okay? And the more weak your muscles are, the more your joint is going to get compressed, and that means it will aggravate your arthritis more. But the idea behind strengthening your muscles is it then supports your joint, and then there's less compression. Okay, so that's usually the first point, making the splint. The second point with CMC joint arthritis is basically working on strengthening the thumb muscles around the CMC joint. There's lots of different research out there, but definitely there's 3 exercises that people are very, very keen on, okay? The first one is strengthening what we call your first dorsal interosseous. So if everyone, I'm going to try and put my hand here, if everyone has their hand and they lift up their index finger, what you'll see right here is this big chunky thing there, okay? That muscle there, you can see how mine kind of goes up and down, just there. That's your first dorsal interosseous. Now, obviously, it's lifting up my index finger, okay? But what it is doing is it attaches down to the base of your thumb down here. So as you strengthen it, it's actually distracting or opening up your joint. So it's the only muscle in the hand that actually opens up the joint, so reduces the compression, okay, with using it. So that's often a really common exercise we get you just start strengthening, okay? We can obviously progress that exercise, but that's usually the starting point. We then do a couple of other exercises. So one of the problems as well with people with CMC joint is, as you notice when I pinch now, you can see this nice lovely curve. But what happens when people have CMC joint arthritis is they kind of collapse here. And you can kind of see with me how that joint has suddenly gone flat. But more importantly, if you look on this side, that's nice there. That's a nice like curve. But as I flatten it here, can you see how this is kind of almost sticking out? And that's what Herman was showing in his pictures, is that joint actually starts to sublux, okay? So what we want to do is we want to strengthen your muscles through here, which is your abductor pollicis longus and your extensor pollicis brevis to help bring this part up. And we also want to strengthen your flexor pollicis brevis. So doing these exercises. So you can imagine as a combined movement, you then work on getting that nice posturing through there, okay? It seems really easy when I'm showing you those exercises, but I promise you they're really hard to do by yourself unless you've practiced them a lot, okay? So I guess in a nutshell, that's kind of what we do in terms of conservative management, okay? But as we said, I'm sure everyone's going to ask, well, what happens if we don't improve significantly over those 2 weeks? So what I kind of say to people is I'm not a big fan of keeping in your splint full time because as we talked about, your muscles get weak. So often at that point, that's the point where I kind of say, hey, go back to see Herman, okay? Go back to him, he'll have a chat, and that's where he starts talking to you about those steroid injections within your CMC joint, okay? And the idea behind that is the splint is trying to break the cycle, but the steroid injection is also trying to break the cycle, probably does it a little bit more effectively because it's going right into the joint, okay? So often by doing that, it helps us settle down that inflammation, and then we can start those exercises and strengthening programs, okay? There's other smaller splints that we can also use to help maintain that posture, and a whole lot of other exercises we can do, all right? As Herman mentioned, people will offer you up to 3 steroid injections before they then start wanting to talk to you about surgery. And there's lots of different surgery out there. The main one that people are doing in Australia, as Herman said, is the trapeziectomy, which is essentially, like you said, they literally take out that bone, okay? So there is no bone rubbing on bone. They grab a little bit of one of your tendons in your wrist, okay? They strip it, they roll it into a ball and go, and they shove it back into that hole, okay? And they get a little bit more of that tendon, and they literally sew it through your bones so it's suspended. So what they call it, it's called a trapeziectomy and a suspension arthroplasty because your thumb is then suspended, okay? So there is no joint, okay? It is literally just bone on tendon, all right? There's no pain. It's great. It's a fabulous surgery. The downsides, you lose a significant portion of your strength, okay? So there are very few surgeons out there who will do this, okay, unless you don't have any strength or very little strength. And also, there's only a very limited lifespan to this, so maybe 10 years at most. So younger people, this is not really an option. 2 surgeries that are kind of coming out at the moment is there's one called a joint denervation. So that is literally where they basically cut the nerves going to your joint so you can't feel it. And it has been said to be as effective as a joint replacement, obviously with much less therapy involvement afterwards. There's a lot of surgeons in Australia who probably don't do it. There's a lot of surgeons overseas who do that. So like I said, it is a little bit, well, do you do it or do you not do it? Some people say that there's maybe only a 5-year lifespan to this, but for me, it's kind of like, well, if it's 5 years without pain, then, and it doesn't mean you can't have the trapeziectomy afterwards, then it's not necessarily a bad option to consider. There's another option, which again, nobody in Australia is doing yet, but there is actually a joint replacement coming out, okay? It has been out for 5 years, okay? But a lot of previous joint replacements, people have had reactions to, they've broken down, they've been made out of silicone and they've had all these other problems. So people are very hesitant to really go down that path, especially in Australia. But the 5-year results have been very promising. I think a lot of surgeons in Australia are watching and waiting for the 10-year results before they then start talking about this. So for me, it's kind of like, this is a wait and see kind of thing. There are things coming in the surgical spheres. So other options like the splinting, exercises, the injection, they're really lovely options to try and just hold off for as long as you can. So I guess that's the CMC joint in a nutshell. I don't know if you want to do questions now, Robin, or if you want people just to write them down, answer them later. I'm happy either way, though. I don't know where Robin is.
I think Robin's gone.
She's just left us. That's all right.
Okay. Now the party's on. We can say
we can pretty much do what we want now. Exactly. So if anyone does have any questions, feel free to unmute yourself and ask. But otherwise, I'll get Herman to just carry on onto our next topic.
All right. So, okay. So I share. Okay. Now, can you see my screen? Yeah. Okay, so Michele, can I ask you if trapeziectomy is absolute last resort? After the procedure, how much strength can will a person lose after the surgery?
Quite a lot. Most people, when they have the surgery, probably only have maybe 3 or 4, maybe 5 kilograms of pinch strength, and they might only have about 2 or 3 kilograms afterwards.
Wow.
Yeah, so it's pretty low. So you certainly wouldn't be able to do a whole lot of stuff. It's still functional and there's no pain, but you'd be quite restricted.
Good, because I normally reserve that referral to patients with minimal strength from arthritis because they've got nothing else to lose, but they will lose the pain, but they won't lose more function. All right.
Exactly.
So, good. Glad to know that there are potentially replacement therapy and also denervation procedure. So definitely we'll get you involved to give us a talk next when it comes, when they're available. Okay, now, so, all right, now let's move on to tendonitis because that's very common. Now, remember I showed you pictures of the hand with the tendons running along the palm and the fingers. These are the flexor tendons. So they help us bend our fingers and grip things. Now, how I explain the structure and the function of these tendons is such that we've got these ligaments and anchors called pulleys being tied down onto, that they tie the tendons down against the bone, onto the bone. And with time, when we get older, when we do a lot of things with our hands, these pulleys or anchors, they get thickened. And there will be more friction between the tendon and the pulley. And then with time, the tendon can get inflamed, or if a person suddenly increase the day-to-day activity, increase the tension of the tendon gets inflamed, then the tendon gets swollen, it forms a little nodule. So when the nodule slides under the anchor or the pulley, it gets jammed. When that happens, you get what we call trigger finger. I'm not sure whether some of you have had this trigger finger before. Basically, when you bend your fingers, you can easily straighten them out. But with trigger finger, you go, whoop, one finger wouldn't go unless you manually go click, and it can be quite painful. So trigger finger, most of the time is an overuse issue. Yes, in patients with rheumatoid arthritis, sometimes it can cause that as well. And management, rest, anti-inflammatory, corticosteroid injection, or even surgery for tendon release. These are the options. Michele, are there things you can do for trigger fingers?
Yeah. Definitely there's things that we can do for trigger fingers. I guess it's a fairly similar concept to arthritis and any kind of pain, is that we're really just trying to rest. So most people, for when they get trigger fingers, their tenderness is here and they click when they're basically bending into a full fist. But what you'll find is if you bend into a hook fist or if you bend into a straight fist, you don't actually trigger the tendon pulling through. So often we literally make you a splint that prevents that finger from kind of coming down into a full fist. And if we can prevent you from making that full fist or irritating that trigger from going through often enough, then what we find, it tends to calm down. Okay. How long it takes, it often depends. Some people come to see me after a week or two. Some people come to see me after 6 to 12 months. So you can imagine that trigger is significantly probably bigger or more irritated from somebody who's had it for longer. Often what I say though is if the trigger is such that you've bent and your finger's caught and you can't straighten the finger back up and you have to physically pull it out, I often say that's usually the point where the trigger is quite big. Possibly the splinting may not be as effective and the steroid injection is probably the more effective way to go. Okay. But that doesn't mean that the splint won't work. It's just that, you know, we kind of advise people it may not be as effective and we might want to push you down to that path of having that steroid injection a little bit sooner. Okay. Same concept applies. If you've had 3 injections because it keeps coming back, people start talking to you about surgery. And it's pretty simple. You saw on the images that Herman had up, there's just a little pulley just here, and they basically just give that a little bit of a nick. So then it opens the pulley up a little bit more. Okay, probably give you a little bit of steroid through there just to help everything kind of glide through.
So you've just finished watching part 1 of one of our recent educational events. Hope you enjoyed the content. If you'd like to access part 2, then you need to sign up for BJC Connect. It's a free platform where you can access not just the recordings of past events, but also access a whole range of upcoming future events and access our team of facilitators live. All of the details that you need to join BJC Connect are now flashing up on your screen. Otherwise, like our staff, subscribe if you'd like to see more information from BJC Health. Look forward to seeing you in an event soon.